But yeah, if we can get started. So my name is Valentine. I'm one of the geriatricians that joined SHN about 11 months ago now. So it's nice to meet a lot of you over the last 11 months, and it's nice to see so many people on this kind of talk. I wanted to do a talk on the perioperative geriatric assessments in hip fracture surgery, just to optimize outcomes in older adults. And by the way, if you hear any noises, any construction noises, I'm in the Gain clinic, so this is kind of what our patients experience as well. So I apologize for any of the drilling that you may hear. So obviously this is a pretty big topic, so that's why I wanted to present about it. So just what we're looking to get out of the talk today, just understanding the rationale for CGAs in the context of hip fracture surgery, identify key domains of perioperative geriatric assessments for hip fractures, explore evidence-based strategies for risk stratification and optimization, and enhance collaboration in the acute care setting. So just to start off, just a case that I think all of us have seen, just while this talk is going on, just imagine an 84-year-old female with hypertension, osteoporosis, mild dementia, is having a bunch of falls at home, comes in with a left hip fracture. What factors would influence surgical, but also perioperative kind of approach? This is kind of a case we see quite often, probably almost every day or every other day, but the complexity isn't in the fracture, it's in the patient. She clearly has a lot of comorbidities, including the dementia, a lot of mobility issues, social supports may become an issue, and medications all play a role here. So just some background data to start. So about 13,000 people in Ontario have a hip fracture annually, and 20% of these people die within a year, and 20% who are independent before their fracture will be admitted to long-term care. So obviously, a huge number of patients are affected every day, and even from a mortality and morbidity standpoint. And from a healthcare expenditure standpoint, hip fractures account for nearly 500 million per year in Ontario. So the next few slides is going to really be looking at SHN data specifically. So at the top here, all this data is from the health quality standard data, which is available through our OneID. The top picture here, it's from 2023. This is SHN, so there was about 385 total number of hip fractures. And in 2024, there was 338. In 2023, the percentage of patients that spent any time in ALC were about 33%, and the median length of stay of ALC in days is 4, and the 90th percentile length of stay in ALC days was 19.7, and this was in 2023. You can see these numbers jump up in 2024. The median length of stay in ALC per days is 6 days in 2024. And then the 90th percentile was about 27.7 days in 2024. And then this is for the 90th percentile. But the percentage of patients that spent time in ALC went down from 2023 to 2024. This next figure here, sorry, let me just, yeah. So this is looking at some data comparing Ontario, and then the region of Toronto, so all the hospitals in the Toronto area. SHN is one of those hospitals, and then the SHN data as well. So what you can see here is that over the last couple of years in Ontario aggregate, in 2023, about 6.9% of previously community dwelling people were admitted to long-term care within 90 days after a hip fracture. And this went down to 5%. And when looking at their discharge disposition, most of them went to another inpatient care unit, but a lot of them went to continuing care or residential care. Some of them went home without support, and then about 19% went home with support, and about 4.84% died in facility. And that's in Ontario. Here in Toronto regions, in the Toronto region, in 2023, that percentage of going to long-term care within 90 days, it was 4.6%, and then went down to 3.4% in 2024. And again, pretty similar kind of distribution here in terms of discharge disposition. But when looking at SHN's data here in 2023, long-term care admissions within 90 days was at 7.4% in 2023 and 6.8% in 2024. So obviously when comparing to the Toronto area and to Ontario, we're at a way higher number than they are. But our discharge disposition locations are approximately the same. However, 7% died in facility at SHN, and 54.26% were transferred to another inpatient care unit, which is way less than Toronto aggregate and Ontario aggregate. So these charts, I made the chart, but all the data is from the health quality standard. It was just easier to kind of show it in this way. This is data showing the 30-day mortality rate of patients that have come in for hip fractures. You can see that provincially, there was a slight overall improvement from 2023 to 2024, from 6.05% to 5.54%. And this was in Toronto as well, which performed better than the provincial averages, which indicates that Toronto hospitals may be leading kind of hospitals in some of these improvements. SHN at the general campus showed a dramatic improvement from 2023 to 2024 in 30-day mortality, went from 9.43% to 4%, and which is way below actually the provincial average and also some of the gold standard. So how I basically chose the hospitals to add to this chart were some local counterparts. So that'd be Lakeridge's 2 sites, as well as North York being local kind of counterparts. And then I added London Health Sciences Center and St. Mike's because just as a quote unquote gold standard, we know that they have pretty robust orthogeriatric programs and things like that. So I wanted to compare to those 2 kind of sites as well. So comparing to other local counterparts, we can look to North York being kind of a local benchmark because their percentages here are 3.06% and 2.53%, which are much lower than the provincial averages and the Toronto region averages as well. But also when comparing to the kind of gold standards, they've done much better as well. This is 90-day mortality rate after hospitalization. So provincially, there was an improvement between 2023 and 2024, and Toronto continues to outperform provincially. SHN at the general site showed an improvement between 2023 and 2024, and approached numbers that were closer in line to Toronto and provincial averages. Also, when comparing to local counterparts and gold standards, we were also closer in line there as well. Again, North York General really outperforms here as well and kind of remained a benchmark locally. So this was 30-day readmission rates after hospitalizations for hip fractures. From 2023 to 2024, there was a slight improvement provincially and in Toronto, but Toronto underperformed compared to the rest of the province. SHN at the general had an increase in readmissions despite improvements in mortality that we saw with 30-day and 90-day mortality rates, but we performed slightly better than the rest of the Toronto hospitals in 2023, but in 2024, our rates were higher than the provincial and averages in Toronto. And this trend continued when comparing to the gold standards as well. I know there's some empty slots, just that data just wasn't available on the health quality sites. So what this goes to kind of show is that there's been an improvement in mortality, but readmissions are kind of an emerging concern. So this is looking at 90-day readmissions. Both the province and Toronto improved from 2023 to 2024. Here at SHN, there was an increase here as well from 12.46% to 14% in our 90-day readmissions. And this was much higher than some of our local counterparts and also well below kind of the gold standard markers as well. This next metric was looking at the median wait time for surgery, which is recommended to be less than 48 hours. So there's 2 columns here, the ED entry, which is defined as those going just through the ED, and the wait time that they calculate is based on the point of entry. while the non-ED entry are those that are transferred to a different site. For example, in our setting, from Birchmount or Centenary, if they get transferred to the general, the wait time then is started once they get transferred to the general and once they get a bed. So in Toronto, there were increases in wait times for both ED entry and non-ED entry. With SHN, our wait times are less than the rest of Toronto, and our counterparts locally and as well as St. Michael. So we're doing quite well in terms of the median wait time. So this was looking at delirium rates. So in terms of delirium rates, there was an increase in delirium rates in Toronto from 2023 to 2024. And SHN's rates for delirium in 2023 were much higher than the rest of the local counterparts. It was at 33.3% at Birch, 19.2% at the General, and 34.4% at Centenary. And this is in comparison to the local counterparts as well as kind of the gold standard markers as well. And in 2024, we performed better than our local counterparts, but not compared to the gold standards. However, I am kind of skeptical about kind of this data because I do wonder how they measure these rates. When I looked at the methodology, it looks like it's based on discharge ICD codes. So I do wonder how accurate some of that is, especially when some institutions may be coding differently as well. So why focus on older adults? So 90% of hip fractures occur in adults aged 65 and over, and the 30-day mortality is about 10%, and the one-year mortality is about 25%. And traditional surgical risk models often underestimate the risk in this population. So there was a study done by Gregorian and colleagues. It was a retrospective cohort study. It involved 600 older adults, and this was done in 2014. Their analysis demonstrated that geriatric consultation during hospitalization significantly reduced 30-day mortality and also major postoperative complications, especially in frail individuals. And this finding supports the hypothesis that risk surgical calculators alone do not capture the true vulnerability of older adults. So this is probably a graph that all of us have seen. It's a percentage of Canadians over 75. It's definitely increasing, and you can see how it's going to increase even more over the next 20, 30 years or so. So this is your typical geriatric comorbid, multi-complex patients with a lot going on. Everything is kind of interconnected. And kind of the big picture wise, there's so many things that are happening from a multi-complexity standpoint, whether that be mobility or polypharmacy, and it's all kind of interconnected as well. So older adults with hip fractures are among one of the most medically complicated patients in the hospital, and it's difficult in judgment between balancing medical optimization and prompt surgery just because of the comorbidities that exist, because of their impaired metabolic responses, management problems when it comes to consent or discharge planning, or polypharmacy as well. So surgeons may not be the best people to look after these patients, and an ideal solution is probably close supervision by medicine and geriatric consultants. So what is a perioperative geriatric assessment? It's a focused CGA, which is a comprehensive geriatric assessment applied urgently in acute fracture settings. So a CGA is a multidimensional, interdisciplinary diagnostic process to determine the medical, psychological, and functional capabilities of a frail elderly person in order to develop a coordinated and integrated plan for treatment and long-term follow-up. So there was a study done by Kammerlander and colleagues in 2010, which looked at, they implemented a geriatric trauma unit where geriatricians were actively involved in acute hip fracture care. It was a prospective study, showed reduction in time to mobilization, fewer infections, and significantly improved functional independence at discharge. So the takeaway is that it's not just an assessment, but an intervention, which includes delirium prevention, fluid electrolyte balance, and early rehab. So CGAs. So the number needed to treat was, in general for CGAs, is 33 in a study done by Ellis and colleagues in 2011. And this meta-analysis looked at 22 trials in the hospital setting. And an update was done in 2017, which looked at 29 trials and came with the same conclusion. This was just some new evidence that came in the last, this year actually. It was by Mazzarello and colleagues in the Bone Joint Journal, conducted the most comprehensive review to date on early CGAs in hip fracture care. Their analysis and review looked at 39 studies encompassing over 25,000 patients. And of the 219 clinical outcomes examined, about 71% were positively associated with early CGAs, including reduced complications, readmissions, length of stay, and mortality. And in terms of patient-reported outcomes, 86% improved with early CGA, including gains in mobility, function, and quality of life at 1, 4, and 12 months. So crucially, the strongest benefits were seen when the CGA was initiated within 72 hours of hospital admission, especially when delivered by interdisciplinary orthogeriatric teams. So this strengthens the case for basically standardized protocol-driven CGAs early in the hip fracture pathway, and not just an afterthought, but in first-line intervention when they walk through the door in the emergency room. So functional status, we're basically going to be looking at different areas that are important in kind of a perioperative assessment. Functional status, so obviously pre-fracture mobility status is critical, predicts rehab potential and discharge destination. So tools we can use is ADLs, IADLs, gait speed, tug as well. And there was a study by Pressmo and colleagues in the Lancet in 2015. It was a landmark randomized control trial comparing comprehensive geriatric care versus orthopedic ward care in 397 patients with hip fractures. They found that the geriatric ward model would focus on mobility, rehab, and cognition, led to a higher proportion of patients living independently at 4 months, with the p-value less than 0.01%. And functional trajectory is therefore not fixed. It's modifiable based on kind of a team-based interdisciplinary team. Cognition and delirium risk. So baseline cognitive impairment is common and it increases risk of post-op delirium. So we can use tools like the MoCA, the Mini-Cog, and the CAM. There was a study in JAMA in 2001 that identified post-operative delirium as a powerful predictor of poor outcomes in hip fracture patients. It was a prospective study that found that patients who developed delirium had a 2-fold increase in 6-month mortality and were 3 times more likely to be institutionalized. This was a systematic review and meta-analysis done by Shields and colleagues in 2017. They evaluated if an early CGA reduced delirium after hip fracture surgery. It ultimately showed a lower incidence of delirium in those that had a CGA done. There was a reduction of 0.81, therefore 19% reduction in the risk of delirium in patients receiving a CGA, and number needed to treat was 11. And a subgroup analysis was done, which showed looking at team versus ward model, which showed a clear benefit in team-based CGAs. Taking a deeper look at frailty, it's a common and modifiable risk factors. We use the CFS, which is a clinical frailty scale, the Edmonton Frail Scale, but frailty is a predictor of surgical complications, delirium, and mortality. And we know there was a study that showed 250 older adults with hip fractures that used validated frailty metrics. They found that frailty independently predicted both 6-month mortality and delayed return to independent mobility, even after adjusting for age and comorbidities. So this is just a figure that shows basically frailty being a state of high vulnerability. So when somebody is a little more independent, this is something we see every day, and I'm really just preaching to the choir here. Even something like a UTI, they're able to bounce back. But if someone is a little more dependent functionally, it takes much longer and a much longer time to bounce back, and they may not even bounce back to where they were prior to. And this is all because of this here, the cumulative deficit model of frailty, which is the number of deficits in an individual over the total number of deficits measured. So as we age, things stereotypically go wrong, and we accumulate these deficits. So as you can see on the left side, there's someone who's running versus the cartoon on the right, sorry, and it's someone who's in bed, spending most of their time in bed. So this change in mobility and change in function commonly coincides with the change of cognition, but also the change in social engagement, which happen as the degree of frailty increases as well. This is a clinical frailty scale developed by Rockwood and colleagues in 2020, and it was published in the Canadian Geriatric Journal. They looked at key features of cognition, function, mobility, balance, social engagement, health attitudes, and the number of illnesses that people have, and translated that into the typical profiles that people will go through as they become more frail. So wanted to kind of highlight a few of these. So the first one was CFS3, which is managing well. So these are, it's the most common patient we'll see. There will be people who are very fit, but they're not really as common. So what does managing well mean? There are people whose medical problems are well controlled, but they're occasionally symptomatic, and they are often not regularly active beyond routine walking. And this is designed for those when you're seeing people in the emergency room. And we talk about baseline, and it's not about when they're in the emergency room, it's about how they're doing at baseline, which is 2 to 3 weeks kind of prior to their admission to the hospital. CFS4, living with very mild frailty. So the very first hint of frailty is very mild frailty. And these are people who are having early transition from complete independence. So they're not depending on other people every day for help, but often their symptoms are slowing them up. So you'll often hear that they're being slowed up or they're feeling tired at the end of the day. So these are people with very mild frailty. Living with severe frailty, this is kind of on the other end of the spectrum. This is someone who's completely dependent for personal care, and they're approaching kind of the end of life. And typically they could not recover even from a minor illness. So they're spending more time in bed, and often they're spending most of the time in bed, not awake. So this person is frail, as well as this person is frail, but the degree of frailty is kind of what matters. And the point I'm basically trying to make is that we can't just say frail and not frail. Frailty is just a commonly used term to kind of to be ageist. But it's important we talk about the degree of frailty and bring about approaches to take that care into account. So this was a study done from Hall and colleagues in JAMA surgery. And what they did was a frailty screening initiative and wondered what it will do to mortality. So it showed that 12.2% of people died at 30 days before the screening and 3.8% after. And the same trend was at the 365-day mark, where it was at 34.5% before the screening and 11.7% after. Now, this wasn't a randomized control trial, but it shows a big amount of what we can do with pretty simple things. So it's super important for us to understand how risky and how important it is to take frailty into account, especially in the hospital setting. So comorbidities and polypharmacy. So cardiovascular disease, diabetes, CKD, they're all very common, and they complicate management, especially for people that come in and have hip fracture and hip fracture surgery, as well as polypharmacy as well when looking at falls, delirium, and bleeding. So there's the stop-start criteria and Beers criteria as well that help prioritize deprescribing. There was a study done by Leal and colleagues in BMC Geriatrics in 2016, where they performed a systematic review on post-hip fracture pharmacological management and interventions targeting polypharmacy, including stop, start, and Beers criteria were looked at. And this resulted in fewer readmissions, less delirium, and fewer falls. So what it shows is that a structured medication review is something that is super important in terms of earlier on in the admission to make sure we're getting the right medication regimen and optimizing them correctly. Nutritional status. So poor nutritional status delays healing, it increases infection risk. So we should be considering supplements early. And malnutrition tripled the length of stay and doubled complication rate in a study that was done by Roth and colleagues in Clinical Nutrition in 2005. Basically, they used albumin as a marker, as a proxy for nutrition risk, and that independently predicted mortality. In addition to early caloric support, involving dietitians on admission improved wound healing and reduced infections. So nutrition is one of the few kind of modifiable surgical risk factors we can address acutely. Social supports and discharge planning. Assessing caregiver capacity, home safety, getting supports in place, and beginning discharge planning on admission is really important to kind of hip fracture care. So a study done by Magaziner and colleagues in Geriatric Society Journal 2000, they conducted a longitudinal study evaluating the post-acute trajectories of over 500 hip fracture patients, and their findings emphasized the critical role of early discharge planning. So patients who had coordinated care, including early physical therapy, caregiver meetings, and social work involvement within the first 72 hours, had shorter hospital stays, reduced time to rehabilitation, and improved 6-month functional recovery. So this study also highlighted that discharge delays were more strongly associated with social complexity rather than medical instability. And a lack of caregiver support and unclear discharge destinations led to longer admissions and increased likelihood of discharge to long-term care, even when rehab potential existed. So it's really important to ask early, can the patient return home? Who will assist them? What services do they qualify for? And what supports will they really need? So putting it all together, combining assessments for an overall picture is really important, and using geriatric flags to trigger multidisciplinary discussion. And chronological age is not equal to physiological age. So there's some geriatric co-management models. They improve outcomes. Kammerlander and colleagues in 2010 assessed outcomes from an orthogeriatric co-management model in an Austrian trauma hospital. The intervention involved daily shared rounds with orthopedic surgeons and geriatricians, and it showed early geriatric assessments within 24 hours of admission, and standardized delirium prevention protocols were implemented. And the results were quite compelling. It showed delirium rates dropping from 41% to 25%. The average length of stay decreased by 3.4 days. In hospital, mortality dropped from 8.2% to 4.5%. And the ortho geriatric unit also saw a higher percentage of patients discharged to home or rehab versus long-term care facilities. And importantly, they found that even minor improvements like optimizing medications pre-op and ensuring early mobilization had cumulative effects when applied systematically. So this model really underscores how important a team-based, protocol-driven care anchored in geriatrics can shift the outcomes and shift that curve in very tangible ways. Communication and goals of care. So hip fracture often marks transition in health trajectory. So it's very important to discuss future function, rehab expectations, and code status, as we all know, and consider frailty, dementia, and prior function when having these discussions. Fried and colleagues in JAMA in 2017 conducted a qualitative study on goals of care discussions in older adults, especially those that were admitted for hip fracture. They found that prognostic framing, like describing likely functional recovery and complications, was more important to patients than survival statistics. So it's really important to use statements like, given your memory loss, frailty, rehab may be limited, or this injury often leads to a loss of independence, because families usually feel a little more supported in decision-making, and it was found that there's less decisional regret later on. And this aligns with the Canadian Choosing Widely recommendations as well, which encourages discussions on mobility, potential for delirium, and likelihood of returning home. Quality standards. So I wanted to go through a few of the Ontario quality standards for hip fractures. So what this was includes 15 high quality statements identified by the Health Quality Ontario's Hip Fracture Quality Standard Advisory Committee. This committee consisted of orthopedic surgeons, pharmacists, physiotherapists, occupational therapists, some geriatricians, namely Camilla Wong, who's really spearheaded orthogeriatrics. And it focused on adults age 50 plus undergoing surgery for fragility hip fractures. And it was from the point of ED until follow-up post-surgery in the community. So the first quality measure, quality standard, was emergency department management. So patients with suspected hip fractures are recommended to be diagnosed within 1 hour of arriving at the hospital, and preparation for surgery is initiated, and patients are admitted and transferred to a bed in an inpatient ward within 8 hours of arriving at hospital. Obviously, no bed admits are what they are, so we can't kind of do these 8-hour ward admissions, but I think diagnosis within 1 hour of arriving to the hospital is definitely achievable. So we can kind of help this by ensuring validated assessment tools, laboratory testing, and making sure imaging is completed at the point of entry. The next quality standard is kind of what we were looking at before in terms of the metrics. Surgery within 48 hours, which is a recommendation. They should receive surgical intervention as soon as possible within a maximum of 48 hours of their first presentation to hospital, regardless of whether they are subsequently transferred to another hospital for surgery. Increased time to surgery causes prolongation of pain, extended inpatient stay, and is associated with increased morbidity and mortality. Multimodal analgesia is another quality standard recommendation. For patients who have experienced a hip fracture, pain is basically one of the main physiological and psychological stresses, and a patient's pre-hip fracture pain medication should be reviewed to assess the need for continuation or substitution while in hospitals. Opiates are effective at relieving acute pain. However, as we know, they're associated with a host of side effects, including confusion, vomiting, constipation, sedation, respiratory depression. And it's important to consider the use of multimodal analgesia to reduce dose-dependent opiates related side effects. And using non-narcotic systemic analgesics like a Tylenol or NSAIDs, if not contraindicated, and also peripheral nerve blocks, such as fascial or femoral nerve blocks, can improve pain control, reduce post-op delirium, and reduce overall opiate requirements. So this was a little sidebar. It's not part of the quality standards, but it's something that has been brought up also at our most recent Canadian Geriatric Society meeting as well, where there was a panel done by surgeons and anesthesiologists that talked about gabapentin and pregabalin. So Canadian surgical and anesthesiology guidelines do not recommend the routine use of gabapentinoids for postoperative pain. Systematic review and meta-analysis has shown that perioperative gabapentinoids do not provide a reduction in pain, and it's associated with an increased risk of side effects. And another recent meta-analysis found that gabapentinoids may reduce pain scores and opiate consumption, but these were not found to be clinically meaningful. So going back to the health quality recommendations, this is not really for us in medicine, but maybe when surgeons kind of, when we're talking to surgeons, as long as we kind of know these things, I think it's important. For stable intertrochanteric fractures, it should be treated with either a sliding hip screw or an IM nail, and then subtrochanteric fractures or an unstable with an IM nail. And if it's displaced intracapsular, should be treated with a surgical arthroplasty. Mobilization is another recommendation. Surgery for hip fracture should be planned to allow patients to achieve weight bearing as tolerated without restriction within 24 hours following surgery. And full weight bearing enables early mobilization, supports patients to return to their pre-fracture level of mobility, and reduces the risk of adverse events associated with restricted weight bearing and prolonged immobility. All modern hip fracture implants are designed to facilitate weight bearing as well. And the goal of post-operative mobilization is to help patients return to their pre-function level of functioning as soon as possible. And the benefits of this include decreased length of stay and fewer complications associated with prolonged time spent in bed. Patients should receive assistance with mobilization at least once each day, more often whenever possible, and from members of the healthcare staff, including nurses. And where safe and appropriate, always encourage the allied health staff to teach family members and caregivers how to safely mobilize as well. Delirium. So patients who have experienced a hip fracture are at risk for developing delirium. Hip fracture patients with delirium are more likely to have a longer hospital stay, fall, develop pressure sores, and die than those without delirium. If delirium develops, it's important to identify and manage the underlying causes or combination of causes and to attempt to treat the delirium. Interventions to prevent delirium and promote recovery include orientation and also creating an environment which provides context. Like, for example, moving the patient to a bed next to a window, or telling the family to bring in familiar things like pictures of them, or their hobbies such as a blanket or knitting items or whatever kind of they do at home. Ensuring basically patients are having all their sensory needs met, so glasses, hearing aids are used when appropriate, and considering alternatives for the drugs that can cause delirium as well. Post-operative management. So care for hip fracture patients should be guided by an orthopedic surgeon, but in collaboration with the clinician familiar with geriatric principles. So management for hip fracture patients should include, at minimum, nutritional intake should be assessed, risk assessment for pressure injuries using the Braden scale or another validated tool. If post-op catheterization is necessary, using an intermittent catheter instead of an indwelling. Appropriate hydration, venous thromboembolism should be evaluated using medical rather than mechanical strategies, unless there's a contraindication, of course. A fall risk assessment should be performed, and a comprehensive medication review and reconciliation should be performed as well. Rehabilitation. On discharge from the acute care hospital, all hip fracture patients, including patients with cognitive impairment and those residing in long-term care homes, should have the opportunity to participate in an active interdisciplinary rehab program. And rehab has been shown to improve patient outcomes with functional status, leg strength, health status, balance, mobility, IADLs, and social functioning. And effective hip fracture rehab program includes therapies to improve independence with self-care, balance strengthening and gait assessments, nutritional supplementation, fall prevention, safety, environmental modifications, osteoporosis management, medication management, pain management, pressure relief and comfort for positional maneuvers, transfer training, stair training, and ongoing exercise programs following the completion of rehab as well. Osteoporosis management is another one of the recommendations from the health quality standards. And as people age, obviously the incidence of fragility fractures increases. So treatment for osteoporosis leads to a reduction in refractures and mortality and a decreased rate of new fractures. So all patients with fragility fractures are at high risk of future fractures, and pharmacological intervention should be offered to these patients while in hospital, subject to contraindications. Bone mineral density scans to monitor treatment efficacy should be considered in those who accept osteoporosis treatment in the outpatient setting, of course. Follow-up care. A follow-up appointment with primary care providers within 2 weeks is recommended after returning home to ensure that patients are recovering well. And also, in addition to the primary care provider, they should have an appointment with the orthopedic service within 12 weeks of their surgery as well, to allow for an assessment of that outcome of surgery and to facilitate a successful recovery as well. So just revisiting that initial case, that 84-year-old female with mild dementia, frailty, and poor nutrition, Interventions could be a geriatric consult, early mobilization, pain control, a family meeting to discuss goals of care, prior functioning, and to anticipate future functioning as well. And things to anticipate delirium, discharge to rehab, cognitive decline as well. So looking overall at the trends of SHN and where we can kind of move towards, going back to what I showed in the beginning, our 30 and 90-day mortality rates have decreased and are pretty comparable to the rest of the province and region. But our 30-day and 90-day readmission rates have increased and are much higher than our comparisons. So is this a question of gaps in post-discharge care, too quick discharges, issues with rehab transitions, kind of open to discussion. Median wait times in terms of surgical wait times are comparable to the rest of the region and province, and our delirium rates are quite high compared to the gold standards and the region. Is this an issue with discharge ICD codes? Do we need better screening and identification? More to discuss there. So future directions. So things that we can think about is the EMR embedded hip fracture CGA tools. We can think about auto consults from the ER for indicated patients and expansions of orthogeriatric models. So in summary, hip fractures demand urgent, tailored CGAs. Functional status, cognition, and frailty are top predictors. And we can help improve outcomes. So consult your friendly neighborhood geriatrician, and we can try to help with all these things to optimize care for those that come in with hip fractures. And yeah, I wanted to open up the discussion and kind of question period. I'm not sure if there's anything in the chat box about questions or comments that people had.
Hi, Davian. Again, I'm just going to take myself off mute. Thank you for the talk. Again, a lot of sort of interesting data. Several questions I guess I just had to ask was, in terms of, I guess, the differences between the community hospitals or the hospitals that you've compared, is there any differences in terms of population or age? Again, I wonder whether or not correct or not, whether or not, again, we're seeing sort of aging population, especially in terms of the proximity of our hospitals to some of the nursing homes that we receive from. And then I guess the other question that I had was with regards to the differences between 30-day and 90-day readmissions. Again, 30-day I can kind of see in terms of it being related to the I guess the surgery or the immediate complications related to the surgery. But in terms of, I guess, a 90-day readmission, is that reflective more of the patient population and, again, the underlying comorbidities? Thanks.
Yeah, thanks, Vince. Those are great questions, and it's actually something I dabbled with as well. I spoke to some of my other geriatrician colleagues as well, but yeah, in terms of comparing us, of course, there's going to be difference in demographics, in terms of socioeconomic statuses, people, what we can offer in terms of services in the community and things like that. But I completely agree. But when also looking at some of the gold standard ones, like for St. Mike's, for example, St. Mike's has a huge kind of population of undomiciled kind of homeless patients as well that come in with fragility fractures as well. So socioeconomically, they're probably a little similar as well to ours. But yes, when comparing some of the local standards, yeah, North York General generally does have a different kind of demographic to ours, which may be contributing to some of the numbers that we're seeing as well. And in terms of readmissions, yeah, in terms of 90-day, I would say I think I'm not sure if it's the lack of kind of community supports we have that are able to kind of keep our patients at home or the complications that are occurring as well. Whether that be because of any socioeconomic factors or because of lack of support from community services or follow-up. I'm not too sure. That's something that I think that we should look at more in the future as well. I think I see a couple of hands up. I'm not sure who went first though. So
Seda, did you have a point?
No, Alexis, you go first, and then I'll comment. You were first anyway.
Sorry, so I have two questions. I'm going to hog some time here. My first question is, my understanding is that the data more recently supports early use of bisphosphonates, and you allude to that post-fracture. Is there kind of a rule of thumb that you go by 2 weeks out or time of discharge? When should we actually be initiating these bisphosphonates?
yeah, the general rule of thumb, yeah, is a couple of weeks out. But what some of us are now doing is if we're seeing them on rehab, for example, we are kind of they're a few weeks out from their surgery. We are starting it as well, especially before they go home, just because we know that patients can't reliably see their family doctor within 2 weeks, or even an appointment in the gain clinic within 2 weeks. So we are kind of starting that closer to discharge as well. We'll usually but obviously formulary kind of dependent as well. Sometimes we'll ask the family, we'll prescribe it, the family will go pick up the Prolia, for example, the denosumab at the pharmacy and bring it in for the nurse to administer.
Great, thanks. And I guess my second point, you kind of allude to some of the data, which was really interesting to see across different hospitals about our rates of mortality and readmission rates. And I think Vince alluded to this a little bit. We did kind of transform the orthopedic service into, the trauma room where patients are being moved cross-site and the ORs are being pushed to daytime, often weekday ORs, hopefully to improve access for our patients to surgical intervention. Do we actually know if we're intervening on a higher percentage of patients with that in mind? And again, whether intentionally or not, are we accepting a higher risk of complication or delirium, but hoping to intervene on more patients in hopes that they will have better pain control and better functional recovery?
That I actually don't know if, from a numbers perspective, if we are intervening earlier. I know SETA has been working with our patient care manager on kind of getting these numbers. So we're trying to accurately kind of look at them and everything like that. And our service at the general is also quite new. I think we started 2 years ago at this point. So I think just in the process of kind of looking at all of that. So I'm not sure from a numbers perspective though.
Yeah, and I think it's important to think about the knock-on effects when we adjust one service. And again, if the goal is really to intervene as many of these patients as possible, maybe we do accept, the higher risks because it's a higher risk patient population, but it's important to be able to know if that's what's driving it. Okay.
Yeah.
Thank you.
Seta.
Yeah. Divian, thank you. It was excellent presentation, and I think very timely and very appropriate. So thank you so much. It's amazing. Now, if Shara is still on, I will ask her to comment on the use of biphosphonates, because that's what she has been working on for some time. And she probably is the best one to give these answers to in terms of what we can do here at SHN. And the last thing I wanted just to quickly comment on Vince's points about the readmission rates. While it's very possible and very likely that it's related to, lack of community supports and the rest of it, what I've personally seen while consulting on the wards is we do tend to designate delirious patients as not rehabable post-hip fracture. And they tend not to be transferred to the rehab based on their confusional status and lack of participation with physio, which is due to his confusional status sometimes, or anxiety they developed on the ward because of pain with movement and the rest of it. I think that this is the area where we might want to look at further and see if we can somehow modify and improve that access. I don't know if my colleagues will agree with me, geriatric colleagues, or not. So it's just, like my personal opinion for now. That's my take. Shara, if you are still on.
Yeah, Shara, if you're on.
Is she?
She is, but I don't know if she may have mic issues. I'm not sure.
She is in the chat, but does not have audio.
Yeah.
Oh, Shara, I'll be working
So she's gonna
your.
type a response and I'll read it.
Oh, okay, cool. So because
Yeah.
I was about to be her voice here, but then Divian will be.
Yeah. Yeah. If there's any other
I
questions.
know she's been working for a long time along the lines of biphosphonates and their use.
Yeah. So she's saying there's no research-based consensus on starting bisphosphonates. However, experts' consensus says you can start as soon as clinically stable.
Are you still typing? Uh-huh.
Yep. I have spoken to many orthos who have recommended giving 2 weeks for bone healing and starting thereafter. Yeah, that's kind of what ideally starting before discharge is preferable. Shara, you type very fast.
No, she does.
And this is actually something that, or
Okay, here's the crown jewel.
zoldronic acid is the best. And this is also something I was going to say. Zoldronic acid is, they discussed this during CGS this year as well. And this is something we need to work on at SHN. This provides 5 years of bone protection with 1 dose. Yeah.
So maybe some work for Susan in her role as medical lead of pharmacy.
Yeah. I could talk forever on this. Next round. Yeah, any other questions or points of discussion?
Looks like no more, right?
No. Thanks everyone for joining. And thanks for the questions, Vincent and Alexis.